Cancer. This talk will be presented to Dr. Javier Cortes. Dr. Javier is a professor of medical oncology on Institute of Oncology, Barcelona, Spain. Dr. Javier, please.
Just 10 more seconds. 1 more minute. No, 10 seconds. 20 seconds. 15 seconds. Presentation. No, it's
one
just
of the IT person.
yeah, it's now it's 5. Okay, 5 seconds now. Okay, good. Okay, so good afternoon. Thank you so much for inviting me to be here and for sharing this session. Thank you so much to the organizers and also to Ross, because this is a Ross-sponsored meeting, this part of the meeting. So thank you so much for inviting me to be here. I think that any of you could do it even better than me, but because I came from Spain, this is also a great opportunity to come to Egypt. This is my 3rd or 4th time, and I have not seen the pyramids. I don't know if you can say pyramids in English. In Spanish, pyramides, much easier. So again, thank you so much. And we're going to discuss over the next 20 minutes about which is, in my opinion, the optimal sequence to treat our patients with HER2-positive metastatic breast cancer. I think it's quite clear for all of us, but maybe we can have some challenges when we have to decide this point. Let me start with the classical Dennis Lemon trial, chemo with or without trastuzumab. And the reason I always show this trial is to highlight the advantage of trastuzumab over not trastuzumab. Look at the slide. The improvement of Herceptin of trastuzumab is 20% for survival. Remember this number, 20%. So if I give Herceptin, I will improve survival by 20%. This is key to understand the new agents, or the agents we are going to discuss today. And again, I'm stopping this slide because it's key to understand that the improvement with Herceptin is 20%. What about afterwards? We know some data with endocrine therapy plus trastuzumab or plus lapatinib. Today we have some data with endocrine therapy plus trastuzumab and plus pertuzumab, but basically we do not have any data comparing chemo-based versus endocrine-based, but it seems, at least in terms of overall response rate, that chemo plus could be better for HER2-positive patients than endocrine-based. What about in the second line, after trastuzumab-based therapy? This is what we had. We had 2 randomized trials, randomized phase 2 with Herceptin, randomized phase 3 with lapatinib. After trastuzumab-based therapy, we have to continue with anti-HER2 therapies. This is what we had. Now we have also pertuzumab, Perjeta there, and you know the mechanism of action of pertuzumab. I will not enter into detail. You also know the randomized phase 3 trial, Cleopatra, which is chemo plus trastuzumab with or without pertuzumab, with the primary endpoint being progression-free survival, which was clearly achieved. Just one comment. The median overall survival 20 years ago without anti-HER2 therapies in patients with HER2-positive metastatic breast cancer was 20 months. The median PFS today is almost 20 months. So these are good news. What about survival? Impressive improvement in survival, hazard ratio 0.68. Remember, with Herceptin, the improvement was 20%. with pertuzumab improvement is 32%. We have more evidence to use pertuzumab with trastuzumab than to use trastuzumab only. What about TDM1 or Kadcyla? I think it's important to remember that this is like a Trojan horse. In Spain, we say that this is like a referee when we have a match between Barcelona and whatever. They go in black because they have to be balanced, but all the time they are in favor of Barcelona. So this is the same. So this is like a Trojan horse. Nobody knows what happens there, and once the Trojan horse is inside the tumor cell, then it attacks. That's why the toxicity profile is so good, because the chemotherapeutic agent this compound has is not seen by the body. So, which data do we have? We have 1 phase 1 and 2 phase 2 trials from the very beginning. I will not make any comments about the phase 1, but let me make some comments about the phase 2 data we had. Kadcyla, single agent, in taxane and Herceptin pretreated patients, overall response rate in HER2 positive centrally confirmed in the range of 50%. Kadcyla, single agent. If you remember the data we had in the same patient population with lapatinib, 7%. Second trial, patients who received taxanes, Herceptin, lapatinib, anthracyclines, and CAPE. Overall response rate with Kadcyla only about more or less 35%. In this patient population without lapatinib, lapatinib single agent, overall response rate in the range of 3%. So my first comment here is, do we need randomized trials for accelerated approval of the drug? With this data, 30 to 50% overall response rate, median PFS from 6 to 9 months, phase 2 large trial, over 100 patients. We need randomized trials for full approval, that's very clear. But in my opinion, at that time, the drug should have been approved in an accelerated way, depending afterwards for full approval of the randomized phase 2 trials. And here are the randomized phase 2 trials, also very well known. Which was the standard of care at that time? Or Herceptin and chemo, or lapatinib and chemo. That's why Kadcyla, TDM1, was compared with lapatinib plus chemotherapy. And the point here is that the primary endpoint was PFS and survival, because we are not in the first line setting. Results: impressive improvement in progression-free survival and impressive improvement in overall survival. And look at this again, which is the hazard ratio for survival, 0.68. It means the improvement in T1 compared with lapatinib plus CAPE was 32%. So we have more evidence to use TDM1 today than using Herceptin in the first-line setting 15 years ago, because the amount of difference in survival is higher. And the beauty of this agent is that we improved outcomes, decreasing toxicity, and improving quality of life, which are the most important adverse events with TDM1, with Kadcyla. 2, reversible transaminitis and reversible platelets count decrease, or thrombocytopenia. So when we analyze quality of life was better with TDM1, with Kadcyla, compared with lapatinib and CAPE. Now, if by any reason we did not use Kadcyla, TDM1, I'm saying these 2 words because we don't have more agents. So if you use TDM1, you use Kadcyla. If you use Kadcyla, you use TDM1. It's the same. So if you did not use this drug in the second-line setting because we forgot or because we were fishing the river. Then we have the Teresa trial, which is another randomized phase 3, this time comparing Kadcyla versus physician's choice, being the primary endpoint PFS and survival. And once again, overall response rate 33%, the same overall response rate we observed in phase 2 trials, PFS improvement, overall survival improvement. And again, overall survival has a ratio exactly the same as in the Milia, 0.68. Improvement in survival by 32%. So the improvement in survival with Kadcyla is better than the improvement in survival we had with Herceptin 15 years ago. So, the question is, I had 2 clearly positive trials. The Emilia, second line, Teresa, heavily pretreated. So when should I use Kadcyla in my clinical practice? Can I wait? Can I use it in the third line? So if this is a question to ask ourselves, let me be a bad guy. If you're asking yourself, why not in the third line, my question is, why not in the fourth, or in the fifth, or in the sixth, or in the seventh, or in the eighth, in the ninth, in the 10th? Easy. Because of this. Your patient is there. If you guarantee to me that the patient will be able to receive a third line, and the fourth line, and the fifth line, then I will enter in the next discussion. But because the future is not known, we have to give the best treatment to our patients as soon as possible. So look at this data. This data come from Spain. We have same data coming from the United States. 50% of our patients, 50, will not receive the fourth line. 50%. So careful, because many of them did not receive third line. That's why we have to use the best treatments as soon as possible. So do not wait to give the best drugs. The future is unknown. But I will give you another reason. The progression-free survival is prolonged. That's fine. But even though, if you are going to use TDM1 Kadcyla afterwards, and you prefer Cape Lapatinib before, the quality of life is worst. So in my opinion, there is absolutely no a single reason in terms of scientific-based data. I'm not talking about cost. I'm talking about scientific-based data to offer Lapatinib instead of TDM1. Am I saying that Lapatinib is a bad drug? Absolutely not. It's a great, great drug and should be offered to our patients as well. But later on in the metastatic breast cancer setting. So just 2 comments about Marianne. Marianne is nice. What is Marianne? Marianne is the first line randomized phase 3 clinical trial comparing chemo Herceptin, it was designed before pertuzumab, compared with TDM1 Kadcyla-based therapy. I don't care Kadcyla plus pertuzumab, forget that. TDM1 versus, compared with chemo and Herceptin. But this is the key point here. The primary point is not to see if TDM1 is better compared with Herceptin and chemotherapy. The primary point is to observe, to demonstrate the non-inferiority progression-free survival. Because we know that TDM1 is a much better tolerated drug. This trial was designed to see if progression-free survival was not inferior. It is true that if it was fulfilled, we have another primary endpoint, superiority, and another primary endpoint, superiority for survival. But the key primary endpoint is non-inferiority for progression-free survival. And these are the results. TDM1 was not inferior compared with Herceptin and chemotherapy. So is Kadcyla a reasonable approach in the first-line setting? No today, because we have pertuzumab, Perjeta. But if we would not have pertuzumab, TN1, Kadcyla, is a very good primary line because it is not inferior and it is better in terms of quality of life. So, just 5 more minutes about brain metastasis. HER2 positive metastatic breast cancer. So which is the risk of developing brain metastasis if I have a HER2 positive breast cancer? In the range of 30 to 40%. Slightly higher for ER negative than for ER positive. I'm talking always about HER2 positive disease. Look at this slide. If I have metastatic breast cancer, the probability to develop brain metastasis if my tumor is ER positive, HER2 negative, less than 10%. If my tumor is triple negative or HER2 positive, in the range of 4 out of 10 patients, 40%. So this is a clear need to develop more treatments. Which data do we have? You remember this trial, lapatinib-CAPE compared with lapatinib, and the primary endpoint of this trial was progression-free survival. But it was observed that the number of metastases in the brain was lower with lapatinib plus CAPE compared with CAPE. And it was said that maybe lapatinib could prevent brain metastasis. This is absolutely not fair to say. If we control the primary tumor or the metastasis for more prolonged period of time, we will also control the development of new metastases everywhere. Indeed, the FDA and the EMA said, okay, demonstrate this in a prospective clinical trial. I will go back to this point in a minute. Overall response rate with lapatinib single agent in the brain, 2 to 6%. Overall response rate with lapatinib plus CAPE in the brain, about 20%. And you can discuss the last trial. Remember that the Bakelot trial, this was not RECIST-based criteria. That's why we have 66%. It was another criteria, which is great, but it's not RECIST criteria. So, can lapatinib prevent brain metastasis? Let's analyze this in a face-to-face, chemo-lapatinib, chemo-Herceptin. And you know the results. Both were equally efficient in decreasing the rate of brain metastasis. So if we control the tumor for more prolonged period of time, we will decrease the appearance of brain metastasis as well. So what about TN1 for brain metastasis? Unfortunately, we do not have many data, but in the Emilia, we have some very interesting data. For those patients who entered in this trial, remember, patients could be entering the trial if they did not have progressing brain metastasis. So these patients had controlled brain metastasis, but the overall survival was better. Once again, if you improve survival, you improve survival, independently if you have brain, liver, lung, or bone metastasis. Do we have some data with Kadcyla in progressing brain metastasis? Not so many, but I just want to show this slide. This slide has been updated with up to 30 patients, but I like this one because it compares the activity in the brain and the activity outside the brain. Only 10 patients. It was very, very similar. 3 out of 10 brain metastasis RECIST criteria response, 4 responses outside the brain, 30%, 40% more or less. So, in conclusion, and in my opinion, which is the optimal first line for patients with HER2 positive metastatic breast cancer, I think it's very clear. Pertuzumab and Herceptin-based therapy. If we have a patient who unfortunately progresses very, very early after the end of Herceptin, maybe Kadcyla could be considered there. And if we were fishing trout or salmon in the river, and we did not give Kadcyla to our patients in the second line, we also have data in the late line setting with Kadcyla. So in my opinion, pertuzumab first line, Kadcyla second line, and lapatinib and or trastuzumab-based therapy should be considered in the third line or beyond. Finally, this is what we had yesterday. This is what we have today. But we need more agents to treat our patients who belong to the green part of these horrible steel curves. And that's all. Thank you so much.
Thank you, Dr. Javier, for your very interesting, informative presentation. We will postpone the question till the end of the session. Thank you.
Please wait with us, okay? In the debate. Yeah. We'll start now the major debates, and we'll start by one of the important debate about using combined adjuvant anti-HER2 therapy, either using for all patients or for selected patients. Dr. Cortes will give or with giving the combined therapy to all patients, and then we will move to Professor Lugo. She is not with giving, but to some patients, right? Both of you have 30 minutes, please.
How many?
Both of you, 30 minutes. 15 for each.
So 15. Okay, great.
30,
Good.
30. Okay, 15.
So 15 each. 1, 5 each. Okay, good.
Okay.
So, thank you so much again for this debate. It's always great to be with Hope here. And please, do not consider the language. English is much better for her. This is not good. So, forget the language. Okay? Please. Please. Okay, so, I am in favor of yes for all patients. Well, my friends, well, for all patients, listen, I am a warrior. I'm a warrior and I'm a fighter, but listen, for all patients, this is a 100-year-old woman with PT1 MYC and 0, ER 100%, PR 100%, HER2 3+. Hello, what are you doing with this? Now, so for all patients, listen, the winner is Hope. The winner is Hope. I am there, look. You won, Hope, you won. So thank you so much for the invitation to be here, but I lost. And that's fine. So if Hope does not mind, I have changed a little bit the title. So is this a new standard of care for many patients? I know that I lost, so don't say you have changed. I know I have changed. I lost. And I lost. So is this a new standard of care for a significant number of patients? This is what I would like to discuss with you. The answer for me is clearly yes. Moreover, I am treated my patients with pertuzumab for 1 year, and I know it has not been approved in Europe yet. Moreover, when I start with neoadjuvant pertuzumab, I continue up to 1 year, even though the drug has been recently approved by the FDA to treat in the adjuvant setting. So I have been doing this for 1 year, even before the affinity data. So what I want to say to you is that I really say yes here. Now, let's start with this clinical case. And look at the title here, just one of many. When we go to ASCO, when we go to ESMO, to San Antonio, even to here, we are talking about numbers. What are numbers? 80% of patients die. Who cares? 80% of patients. No. This is not one number. This is not one patient. This is your patient who is in front of you. This is your daughter, your wife, your mother. It's not your mother-in-law. Okay, that's another point. That's a number. Okay? So this is important. So when we are talking about, and I know that we have to talk about costs. I know that. But I want to talk now about patients. About our patients. Not about patients worldwide. About our patient. The patient who is there with her children, her husband, her job, and her family. This was a T2N0M0, grade 3, ER negative, PR positive, PR negative, HER2 positive disease. So this is the real life. And sometimes it is black or white. So the patient will be cured or not. That's it. We can say, well, life is gray. No, life is gray, no. For these women, life will be black or white. There is not gray here. So Real Madrid is now behind Barça. This is black for me. It's not gray. It's black. So this will be black or will be white. So when to consider neoadjuvant approach here, I know that this is not the topic for me, but in general, for patients with tumors higher than 2 centimeters and or nodes involved, I would consider neoadjuvant approach. Why? Because we'll have a most important likelihood to decrease the rate of micrometastasis afterwards. Is important PCR as a surrogate endpoint for HER2 positive breast cancer? Yes, but also for ER positive HER2 positive disease, not only for ER negative. So if your patient with ER positive HER2 positive disease has pathological complete response, the probability to be cured is higher. How can we prove PCR? Very quickly here. Look at the data. This morning we were discussing about this. 1/3 of our patients with Herceptin-based therapy will recur. And we know that with pertuzumab we improve progression-free pathological complete response. That's very clear. Look at this. 75 to 100 patients each arm. But look at the progression-free survival. Absolute benefit at 5 years, 5%. 5% hope. Remember these numbers. It is not significant. It was not pre-planned. This was not the primary endpoint, but 5%. So the patient I told you before, 5% more with pertuzumab. 5%. Is this important? 5%. For my daughter, key. Key. And for Hope's family as well. And she knows. Look at the hazard ratio in the range of 0.70. So, which data do we have from ASCO? Let's remember very quickly the adjuvant large trials we have. Look at the hazard ratio with the HERA trial. Hazard ratio with the HERA trial, 0.76 for disease-free survival. 76. Nobody discussed the role of Herceptin after chemotherapy. Nobody. The absolute benefit at 4 years, 6% with the HERA. Now, affinity. Affinity is chemoherceptin with or without pertuzumab. Primary endpoint, invasive disease-free survival. Why invasive disease-free survival and not disease-free